And we're live.
Great. Good morning, everyone. I hope that you can hear me and see me. This is Dr. Stephen Lane from Sutter Health. I'm here to kick off our California State Advocacy Day and virtual campaign session for HIMSS Northern California. We're doing this a little differently this year, given the current situation with COVID-19. I'm going to be making a presentation in my role as the board chair at the Sequoia Project, and then Jen Oldenburg will be following. Jen is from Participatory Health Consulting, and she'll be discussing cross-industry research collaboration, designing digital behavior change. So with that introduction, we do have public chat running, as well as the ability to ask a question using the button at the bottom of your screen. And we hope to leave some time for questions at the end. So if we can start the slides, that would be great. I don't see the slides, but perhaps the rest of you do. If someone can put something in the chat, letting me know if we have slides, I will. Oh, good. There I see slides. That's excellent. All right. Well, hopefully you can all see this. So as I said, I am speaking about the Sequoia Project, providing an update on nationwide health IT interoperability. I've spoken at this forum, the State HIT Day, a number of years in the past, speaking about interoperability, but I'm focusing a little bit more specifically this year on the work of the Sequoia Project. Next slide, please. So a little background on myself. For those who don't know me, I am a practicing family physician and clinical informaticist at Sutter Health. And as mentioned, I also work closely with the Sequoia Project, where I serve as the board chair. On the next slide, the Sequoia Project itself, for those of you who don't know it well, has been around for a number of years, and it supports multiple independent initiatives that each have their own mission, governance, membership, and structure. But the key focus is to support the secure exchange of health data across the country. Next slide. Sequoia Project does have a number of very specific initiatives, some of which you may have heard of. The Pulse system, which started in California, provides disaster healthcare volunteers with access to information to treat individuals who have been injured, displaced, or otherwise being seen in alternative care sites in the setting of disaster. The RSNA Image Share Validation Program helps to test interoperability of medical images, and the Interoperability Matters Forum has been put together to engage leaders from across the healthcare spectrum to focus on solving challenges related to interoperability. And I'll talk about these in some additional detail. Pulse, as many of you probably know, because we've had this now in California for a number of years, can be used by disaster healthcare volunteers. They log into a web portal. They are authenticated against a database of credentialed volunteers, and then they are able to query healthcare organizations for current clinical data to support local care. This has been used in our wildfires. And on the next slide, you can see that we've stood up a national instance of Pulse, specifically to help address the COVID crisis. And the idea here is to allow public health authorities as well as clinical providers access data. This was rolled out initially in Washington State and is now rolling out in some other jurisdictions around the country. We are not using Pulse COVID in California. Its authentication requirements are a little bit lax, or more lax, I should say, than what we use in our California Pulse, which is currently being used in California. Next slide. Just a little bit of a perspective about the work that's going on. The real focus has been on developing a national solution that exists, that leverages existing health IT and networks. So this is why the e-health exchange and care quality have gotten involved really primarily through the Sequoia project in supporting the development of a nationwide pulse to support COVID-19. This is based on the idea that HIPAA permits healthcare providers to share information with public health. When public health requests information on patients for non-treatment purposes, HIPAA does, however, require that we share only minimum necessary information. And this has been a little bit of a challenge in the rollout of Pulse COVID because provider organizations really, many of us feel a need to assure that there is a declaration or a statement that public health is requesting minimum necessary information. We have been working over the past couple of months to try to assure organizations that they can release data to public health for these non-treatment purposes. We have been working with the Office of Civil Rights at HHS, which regulates HIPAA, and have been working with them to develop clear nationwide guidance. We anticipate that there may be some fruit borne in this area in the coming weeks, so we're looking forward to that. There's also been work at the state level as well as at the individual jurisdiction level. For example, the city of Chicago issued an ordinance about a month stating specifically that they needed to get information from provider organizations, and they declared that what they were requesting was minimum necessary. And then another option is for healthcare providers to implement policies that would support this release to public health for non-treatment purposes. But again, we've been scrambling a bit over the last month or two to be able to stand up this Pulse COVID and get it to be used more extensively. And it really shows the opportunities that we have to address these issues, ideally before a crisis, rather than as the crisis is unfolding. Next slide. Interoperability Matters, as I said, is another initiative of the Sequoia project where we focus on prioritizing and addressing issues related to interoperability, providing input to both government and the private sector. This is really meant to provide a public good and a scalable, repeatable process that we can use in the future as different interoperability initiatives roll out. The current work has been focused on patient matching, information blocking, and TEFCA, and we have plans to launch groups that will be focusing on data quality and really whatever is the next major challenge that shows up for us. Next slide. So again, the information blocking work group within Interoperability Matters has been hard at work. They have provided input into the Sequoia's project's comments to ONC on the proposed rule. And now that the rule is finalized, there has been additional work going on, especially in the area of information blocking. The plan now is that we are working on a playbook and a set of resources that will support local organizations in implementing the changes that will need to be put in place to support compliance with the new information blocking regulations that go into effect for all providers on November 1st of this year. The next slide. The latest thing that we've been doing at Sequoia is serving as the recognized coordinating entity, working with the ONC on the development of the Trusted Exchange Framework and Common Agreement, or TEFCA. Next slide. Whenever we speak about the RCE work, we have to make it clear that this is all being supported by the ONC under a cooperative agreement, and that whatever I say today is not specifically been endorsed by the ONC, HHS, or the government. They are very careful to assure that their communications are all reviewed. So this is not a government sponsored presentation. On the next slide, you can see the general timeline related to the TEFCA work. You can see that TEFCA Draft 2 was released just about a year ago. there was the determination that the Sequoia project with some partners would serve as the recognized coordinating entity, and that was announced last fall. The Common Agreement Draft 1 is being worked on presently by a focused work group, and will be released later this year for public comment, and then will go into production after that comment has been received and processed. On the next slide, the various components of what the RCE has been focusing on: the minimum required terms and conditions, or MRTCs, the additional required terms and conditions, ARTCs. We've been very focused on gathering stakeholder input, really working with ONC to develop a process to bring public engagement into this development process. The outcome of all this will be the QHIN technical framework. QHIN stands for Qualified Health Information Network, and this is being developed based on those required terms and conditions. I mentioned the Common Agreement Work Group that is working, and I think has a meeting even today, that is working to develop that common agreement for public comment, and then also metrics to be able to keep track of how information will be flowing across the TEFCA through the QHINs. Next slide. So the next steps regarding the work of the RCE, I mentioned the Common Agreement Work Group. Monthly informational calls are ongoing, and you can find details of those on the web. We are working to evolve with ONC drafts of the QHIN technical framework, and that work is ongoing and will be posted for comment later this year. There is a link there at the bottom if you want to get more involved in this process. Next slide. Many of you are aware that the Sequoia project was central in launching the eHealth Exchange, a nationwide health information network, as well as Care Equality, which is a framework that allows information networks to connect to one another. Care Equality is very much involved in the TEFCA work, and we anticipate that the final TEFCA will really build on the work that Care Equality has done over the past few years. eHealth Exchange as a network is looking at the opportunity to become a QHIN, a Qualified Health Information Network, to participate in the TEFCA. Next slide. I will breeze through these a little bit just to explain that we actually go on to the next slide. So this is the latest statistics on eHealth Exchange. It's a well-established nationwide network that many of our organizations in California participate in. It's been very effective, especially in connecting the federal agencies to provider organizations across our state and across the country. On the next slide, I just want to take a moment to discuss electronic case reporting, which is a project that the eHealth Exchange is currently supporting. This allows reporting from provider organizations to public health entities. We have been doing a lot of work with this since the COVID crisis hit, focus on ECR for COVID case reporting. If you go to the next slide, it will show what are the data elements that are pushed as part of the standardized HL7 electronic initial case report document. If you go to the next slide, you can see how this works. Basically, participants, be they clinicians or laboratories, but especially clinical organizations, when they make diagnoses of COVID-19 or have a positive COVID test, they can send a message through the eHealth Exchange to the American Public Health Laboratory Association, or APHL, which has a hub that then routes those messages out to local public health authorities, as well as creating uploads to the state, which can then report on to the federal or tribal agencies. On the next slide, without going into too much detail, this explains how one slide back. We're going the wrong direction. Back. There we go. This explains the legal agreements that allow participants in the eHealth exchange to be able to leverage existing legal agreements to send this data across. Now we'll go to the next slide and talk a little bit about care equality. I know I'm going fast, but I want to cover a lot of information and give Jan a chance to present as well. So go back one slide. I think we're jumping. Well, we can stay here. That's fine. That's fine. Go ahead. Care equality, again, is a framework that allows health information networks and other HIT vendors to connect. This slide, we just updated it this week, describes on the top half all of those implementers that are already engaged with care equality. You can see here you've got the Health Exchange already on board, the Commonwealth network, which connects a number of vendor systems, has implemented care equality. The Epic Care Everywhere network is also implemented, and a number of other folks. Some of these folks like SureScripts, Know2 on the upper right are vendors that help to onboard other smaller organizations. So we've really developed an ecosystem that allows all sorts of networks and stakeholders to connect. Those in the lower half are those that are in process in implementing through the framework. And you'll note in the lower right a number of imaging vendors who are also coming on board to allow and support the exchange of full DICOM images across the care equality framework. Next slide, what's coming up with care equality. We are working on, we have a work group that focuses on document content to improve the fidelity and completeness of data that's being exchanged across the framework. That group has recently decided to focus in on discrete laboratory results. And it'll be very exciting. We're focusing that work initially on COVID-19 and being able to move that lab data across the framework. We're looking at coordinating care team notifications, so push notifications across the framework. We've done a lot of work to be able to leverage the framework for FHIR-based data element access and exchange. I mentioned image sharing. And then related to the electronic case reporting I mentioned earlier, which is now being supported through the eHealth Exchange, we are also on the verge of completing an implementation guide to allow those who are connected through care equality but are not yet on the eHealth Exchange to be able to do electronic case reporting through this means as well. We're also looking at additional support for care coordination, such as bringing in social services users. We're looking at life insurance as another use case. So care equality continues to expand its reach with regard to use cases and data. So there again, if you want to get involved in this one, you can reach out to care equality. Next slide is really the end of my whirlwind presentation. I got it done in 20 minutes. I'm excited. That should leave time for Jan to present and for us to take questions. Again, my contact information was included in my slides, and if people need to reach out with questions, feel free to do so.
Thank you, Stephen. I really appreciate it. I am hearing a bit of an echo. Is that gone? I think it is. Let's bring up the slides. And while we're bringing them up, I'll tell you a little bit about my background. I am a digital health consultant, have been working in the field for a long time. And I'm going to report on some work from across industry collaboration today. But in the meantime, I have been deeply involved in the past in the Northern California HIMSS group as everything from the secretary of the board to the chair of the board. And it's wonderful to be back, even if virtually. I have also chaired the Connecting for Health Committee on National HIMSS for 4 years, co-chaired, and I'm currently on the board of the Society for Participatory Medicine. I also have a couple of books on digital health out, published through HIMSS. So happy to be here. Anyway, if we move to the next slide, I'm going to talk about a research initiative that has been going on for actually the past 3 years. Next slide, please. And I'll tell you a little bit about what the Digital Health Collaborative is, and then how we research it and what some of the findings have been. So it's really a partnership involving non-competing organizations from all parts of the healthcare ecosystem. So we have health systems, we have insurance providers, we've got solution providers of one sort or another, as well as pharma. And I am an unpaid advisor to the group, which is actually run by Stone Mantle, which is a market research firm. And we focus on everything from doing thought leadership around this topic to collaborating across the groups. And then its bedrock is a great deal of consumer research that I'll be talking about. Next slide. We can shift to the next slide, please. This is the list of the people who have been involved. On the bottom half, you see some of the consumer companies who've actually been doing this for 7 years. And then on top are some of the healthcare companies. Each year, it's a slightly rotating cast of characters, but there's continuity across and in the methodology. And if we move to the next slide, I'll talk a little bit about the methodology that we've used in doing this. And let's keep going. Each year, we look at one big challenge that we want to look at. And the 2020 year, it has been, what does stupid, smart, dumb, and genius look like in healthcare? And it's built on a model that looks at how people want to experience their digital interactions, and looks at, in particular, how that works in healthcare. Each year, using that focus, we identify 3 key charter questions that everything's going to revolve around, and then each member company creates a scenario that they want to research. So we've always got sort of 3 levels of research going on. And if we go on to the next slide, we'll see that in the process, we do 2 rounds of ethnography each year. And this is where we actually work with a smaller group of people, ask them to perform specific challenges, interview them regularly, and look at what their experiences are in the areas that we're researching. We then do 2 rounds of co-creation design with people, looking at solving specific problems and getting their input into it. So it's user-centered design. And then each year we do a large quantitative study. In between each of these, we're working together, looking at the results, assessing what they mean, and doing collaborative sharing. If we move on to the next slide, it shows that over the past 3 years in those various forums, we've talked to a total of 5,071 consumers. And that actually doesn't include the research of the Quant study for this year, which is just in, and adds another 1,200 people to the Quant methodology. So it's been a pretty thoroughgoing set of research. And if we move to the next slide, we'll talk about some of the findings and what we found out about consumer attitudes. And let's keep going. So in the research, we did some segmenting so that we could understand how people really looked at their health, thought about their health. And one of the areas that I think is quite meaningful is they're what we've called context comfortable. And it's really a measure of how people feel about sharing their data and with whom. So we looked at types of data that they might be comfortable sharing and asked them questions about a variety of organizations that they'd be comfortable sharing with. And then we asked them things like how frequently they would be comfortable sharing and how often. So I'll go over some of those results. And if we go to the next slide, we also looked at the patient activation. Oops, sorry, not quite there yet. One of the big results from the context comfortable research is that 53% are very comfortable sharing their data. No, you can move on to that slide. Yes, thank you. So there's a spectrum here, and the people who are more comfortable sharing their data tend to be more comfortable with all things digital. The people who are less comfortable just do less with digital tools. And we've looked at the age banding. It's not as significantly age banded as you would expect. There are people in the younger age groups who are really quite reluctant to share their data, and people in the older age groups who are very comfortable. So that's been an interesting finding as well. And if we move to the next slide, we will look at the patient activation measure. I'm sure many of you are familiar with this. It's a measure developed by Judith Hibbard in the, I think, 2004. And it's been correlated to people's level of activation around their health, and everything from their willingness to use digital tools to their cost has been correlated to the more activated they are, the more engaged in a variety of ways they are with their health. And as you can see here, the population that we were researching skewed a little more than the US population in general toward the higher levels of PAM. The people who are more activated around their health. But we looked at it across. And so if we move to the next slide, I'll talk a little bit about some of the things that we found. This is a little bit about the demographics of each of those groups. One of the things I thought was fascinating is that the people who are at the lowest level of PAM, the disengaged and overwhelmed, are actually, for our research, the youngest population. So you can see their median age is significantly younger, but they're also more likely to be caregivers, and they were a more diverse population than the rest. So all of those things correlate with some of what we're seeing today in terms of the impact of social determinants on some of the health activation and other factors that truly have a huge impact on things like exposure to COVID and likelihood to get sick. So let's go to the next slide. One of the things that we found when we looked at PAM scores in relation to context comfortable is that while in general people at the higher levels of PAM are more comfortable sharing their data, you can't assume that if they have a high PAM score, they're automatically comfortable with digital and sharing their data, though they're more likely to be, and that if they have a low PAM score, they are less comfortable with the sharing their data. So if we move to the next slide, we'll talk a little bit about who the people are willing to share their health data with. And it won't surprise anybody in this group that people are most likely and most comfortable with sharing their health data with their doctor. They are less comfortable sharing it with a family member or friend, and then it drops precipitously to health insurance, pharmacy, online communities. So this is a fascinating finding because they really are not very comfortable sharing their data with a government entity or with their employers. So it's a warning sign for everybody. And if we go to the next slide, we also asked them about who they were most likely to trust to provide a digital assistant. And I have focused in these slides on trust because it's such a significant measure of how they think about their healthcare data. But while they were willing to trust a digital assistant from a healthcare company, in fact, more willing, there was actually a significant group that didn't feel as if the provider of the services matter. And if they were high context comfortable, they were far more likely to be willing to trust a virtual assistant, no matter who it was from. So if we move to the next slide, the things that they would be interested in using a virtual assistant for were hugely to get initial diagnosis and to provide some insights into their health. And I see this didn't translate perfectly to the slide, but it'll be better when we send them out. Let's go to the next slide. We also asked them about a consolidated health record, and this ties back to the need for healthcare interoperability. And across every level of PAM, people thought it was either extremely important or somewhat important that they had a consolidated view of their health record. So the issues with hyperportalitis and seeing only a slice of their data from every provider are real and significant for everybody across all levels of activation. If we go to the next slide, we ask them a little bit as well about what kind of data they would want included. And so while the standard things that we currently have included in most portals, medical conditions, the labs, the medications, some of their historical data and vitals, as well as doctor's notes, are all included. You can see that while every level of PAM thought they mattered, the people at the higher activation levels thought every kind of data mattered more. So this, I think, is instructive if you're thinking about what features to add to your portal, but also how to think about interoperable data and what to do with it. This is instructive. On the next slide, we also asked them some questions about, on the next slide, about their, I believe it's about their patient story and how often they have been asked by their doctors to share their patient story. And one of the things that we noted is that actually very few people get asked by their doctors about their patient story. And a slightly higher percentage have shared it nonetheless. But it's telling that a lot of the communication actually in the doctor's office is one way, and it may have a bearing on people's both health and their activation and engagement levels. If we go to the next slide, I have included a quick survey that we've just pulled out of the field to get a sense about the impact of the pandemic, and in particular, some of the virtual health options. So we put it out in April and in May, and we got about 1,000 completions over those 2 months, with a real mix of genders, income, status, and education. So it just got pulled out of the field yesterday. And again, we were asking a very narrow set of questions in comparison to the broad set we normally do. If you move to the next slide. One of the things that we asked was about a virtual visit and whether they've ever participated in a virtual visit, first of all. And you can see that actually quite a lot of people have participated in a virtual visit. It's about 30%. But of those people who had participated in a virtual visit, a really high number is in the last week or the last month. And most of them have had one virtual visit. Very few people still have had more than one. On the next slide, we highlight what they thought of it. And generally, there's still a high leaning toward in-person visits. I actually thought surprisingly high given how much people value digital convenience. But people are starting to say, well, even though I prefer virtual visits, in-person visits, virtual visits were okay. And some people found them about the same. But people who are younger are much more likely to prefer virtual visits to in-person. So it is a place where the demographics really have a bearing. And one of the things we're looking at is how do you make virtual visits more productive and more meaningful to the individuals involved as a experience with the healthcare system. So if we move to the next slide. One of the things that we have looked at across all of the behavior change work that we've done is how the research findings that we have looked at compare to some of the standard approaches to behavior change in the marketplace. And you can see that for each of them, we have looked at some of the key alignments and what they mean for what you should be doing in the context of involving people with their own health digitally. I do think one of the things that's most interesting to me is some of the findings from behavioral economics that seem to indicate that people, one of the reasons people don't change their behavior in the present is because they don't have a lot of empathy for their future selves. And if you can do things that create more empathy for their future selves, they are more likely to engage in healthy behaviors in the present. That's one of the things we've been experimenting with, is what kind of exposures work and how to do that effectively. On the last and I think final slide, we've highlighted some of the lessons learned, and the idea that we are still left of the boom comes from one of the people on the team who comes from a military background, and this is a term that the U.S. military uses, that, but we're adapting it here to use in terms of we have not yet reached the apex or the real explosion point in digital health, although we think the pandemic is having a significant impact on that. But today, we know that the activation and trust in the institution have a significant impact on people's likelihood to use digital tools, and that their willingness to share data depends both on who's receiving it and who created the tools that are collecting it. So trust in the institutions and in the people make a lot of difference in this. But if you design for personalization and the context in which people will be using it, you're more successful. Everyone was more likely to share their data if we explained how it would be used and who would be using it. And getting to the stage of genius where you're anticipating people's needs and responding to them in the moment is kind of the apex of digital experiences, and we're mostly a long way away from that in healthcare. So if you want to do behavior change appropriately, you need to take all of these things into account in moving forward. We also know that when you are thinking about generating trust from people, that some of the key things involved include, for one thing, respecting people's time, showing that you are not leaving them hanging out in a waiting room, real or virtual, that you're respecting their safety and you're respecting their data. Being transparent about data use is huge in generating trust in your institution and in the tools you're using. And respecting the person and showcasing that by trying to individualize your presentation as much as possible. Give them tools that we call them superpowers, artificial intelligence capabilities, and things that really make it feel as if you have personalized the experience to them. Make a huge difference in the way they engage with your tools and the way they engage with you to alter their behaviors and engage more healthily. So I think we're ready to open it up for questions.
Thank you, Jan. That was a great presentation, and we have received a few questions that we can work our way through, and we invite other participants to chime in with any questions that they would like. We have really done a great job sticking to our plan of 20-minute presentations and 20 minutes for discussions, so that's great. Nancy Hall was the first one to chime in with a question, which was, how does the Sequoia project impact the move towards telehealth? And I think it's a very interesting question, Nancy, and thank you for raising it. We have not been focused within Sequoia on issues of telehealth, but rather on issues specific to interoperability, as I mentioned. But being a practicing primary care physician and now providing telehealth for a long time, we were at Sutter Health the first organization in the state to implement an EHR tethered patient portal now 20 years ago. So, I mean, certainly portal communication counts as telehealth. as do telephone encounters and virtual visits with video support. And over time, we've, of course, done all of those. And so I have 20 years of experience doing that. And I can tell you that as we now transition from, portal-based messaging to telephone encounters to video visits, that really the success of this work depends on our underlying health IT infrastructure. I mean, it's great if you can, whip out your phone and find some random telehealth provider and ask them about your sore throat or your UTI symptoms, or, whether or not you have an STD. But if you're really talking about taking care of people in the context of their coordinated care, if you're talking about chronic disease management, if you're talking about complex patients, if you're talking about how does telehealth fit into a robust care system, it really does that to the extent that that system is itself digitized. When I see a patient, as I'll be doing in an hour here, on a video visit, I have their full longitudinal health record available to me. I have full connectivity with other care providers that are part of their care team. And we have the interoperability tools so that when my patients get, admitted at Dignity Health or at Stanford or at Kaiser, or they are receiving quaternary care from UCSF and primary care from me, all of that information flows together and I can effectively provide care. That's not that different than in the office. Office-based care can be disjointed, telehealth can be disjointed, or it can be coordinated. So I think that the interoperability tools that Sequoia has been supporting, whether we're talking about, the eHealth Exchange and the ability to connect to federal partners, whether we're talking about the Coming Image Exchange and the standards supporting that, all of that will support telehealth in the same way that it supports face-to-face health. But in terms of the evolution of telehealth itself, Sequoia has not specifically engaged in that. And Jan, why don't you take a swat at this one too?
Yeah, and while I know less about the telehealth project, I can speak to some of the issues with implementing telehealth in the current environment. And one of the things I think that has been a laggard feature, or a reason that it hasn't been adopted as quickly, certainly part of it has been difficulty inside the healthcare systems in figuring out how to schedule those virtual visits and how to intersperse them with regular visits. It's one of the reasons a number of organizations have hired external firms, or that insurance companies are promoting options where it's sort of a dial a doc kind of thing. But I very much agree with Stephen that the more linked that telehealth is to the rest of your systems of care, the more information that is available to the telehealth provider in the context of the visit, the more that information becomes a part of your overall care record and so accessible to your primary care doctor or your specialist, the more likely it is to really feel meaningful and to feel like a part of the fabric of your overall care. And one of those things like a consolidated health record that builds trust for people in the system and builds trust in how their information is being used and how it has access, who has access to it. I think one of the great things, honestly, one of the few great things about COVID-19 is the way that it is forcing organizations from large to small to figure out how to incorporate telehealth in their practices. And I suspect that there will be, while we'll go back to some level of the way it was before, that the consumers alone are unlikely to be willing to go back to a no telehealth situation for at least minor problems.
Thanks, Jan. So I noticed that the question function has the ability for participants to add their votes to questions. And when other people give a thumbs up to a question, it bumps it to the top of the list. So Jan, I think the next question, the one at the top of the list, is for you.
So the question is, that I mentioned, trying to create empathy for one's future self to drive action. And they asked what kinds of methods are used to create that empathy. And one of the earliest studies on this was actually by a guy in California. I'm trying to remember, I think he was at UC San Diego at the time, but I could be wrong on that. And he actually first started out with checking rates of savings based on empathy toward your future self. And he started out by just aging pictures of, take a picture of me right now, age it 5, 10, 20 years, and see what impact it had on savings. And not surprisingly, people saved more when they could see what they were likely to look like at the age when they benefited from the results of those savings. We've been playing around with that in the context of healthcare and what impact it has. There, unfortunately, aren't any great studies about it. The guy who did the original study on the savings rates tried an initial one, and a very rudimentary one actually, on obesity by giving them a picture of an avatar that was either skinnier or fatter if they'd lost weight, and that was not effective. So it clearly has to be very personalized to have an impact. We've also looked at some options using virtual reality techniques and how we can give people the experience in virtual reality of bearing either the positive or negative consequences of some of their health behaviors in the present. And that actually shows some promise. And there are a couple of both studies going on and attempts to activate that from a production standpoint. So watch this space, because I think it's a really interesting one. Another part of the that we looked at is oftentimes what creates that moment of impact for behavior change is having a health crisis. You know, you get hospitalized because you have the heart attack or the heart attack scare, or you are newly diagnosed with diabetes with all the life changes that brings. And we've been trying to look at whether, again, some of those virtual reality techniques can help us to create the impact of the health scare without actually having to go through it. So looking at anticipatory behavior in that respect. Jury's still out, but I think it's a really interesting area of study.
Great. Let's go back to Nancy Hall. She and Liz are the only ones asking questions so far. So Nancy asked another question: how do the survey results, and I think you're referring to the surveys that Jan presented, impact the future of digital health and technology programs like the Sequoia project? Are these types of survey results being considered in development of the program? I mean, I'll comment from the Sequoia perspective, and then you can take it a little bit more broadly. But at Sequoia, interestingly, we recently changed the composition of our board to very intentionally bring on board two people whose role is to represent the patient community. So these are people who are patient advocates, and we brought them directly onto the board. So they now constitute, I don't know, like 15%, 20% of our board. And they're amazing. You know, as the board chair, I had a chance to meet with them and talk to them about their focus and enthusiasm. So that doesn't get specifically at these survey results, but it does get at the importance of the patient perspective and patient needs in evolving health IT programs generally and interoperability programs more specifically. I actually love the idea of bringing these survey results to institutions like the Sequoia Project or others that I'm involved in, Direct Trust, et cetera, and really surfacing these to take full advantage of them. And maybe we can work on that together after this webinar, Jan. But why don't you try to address this more broadly?
Yeah, and so first of all, we'd love to do that. And there's, as you can imagine, from 3 years, there's much more depth behind the summary I gave here. And I will also mention that I am on the Ethics and Privacy Advisory Board of an organization, a nonprofit newly formed to support COVID research. It's called the DataVant Project, and they're pulling together findings from a wide variety of organizations of different types, all of it de-identified data, and allowing researchers to look across that whole group of data for insights into, in particular, COVID-19. And I'm helping advise them on the policies along with both patients and other consumer privacy advocates on what they should be looking at to protect the privacy of people while disseminating the maximum, getting the maximum value from this huge research database that is now available. But I'd like to say also that when we think about research like this, you know, one of the things that all of us have known intuitively for a long time is that, yeah, people really do need their consolidated longitudinal health records. People need that, their doctors need that, and often, you know, the care is either duplicated or delayed because the relevant provider doesn't have access to the relevant information at the relevant time, or isn't able to see that information in a way that tells a quick, coherent story and allows either party to dive deeper in the moment for that information. So I think there's a huge potential as we are in an environment where we're finally really addressing interoperability, where ONC is supporting it in its rulemaking efforts, at looking at how we not just consolidate it, but consolidate it in meaningful ways that help both patients and providers make decisions in the moment. And that's one of those things that bringing the right information to bear in the moment is a significant player. And when you think about adding patient-generated health data to the mix of data that's both interoperable and available in the context of a consolidated record, you start thinking about the great promise that's there and also the potential to do it badly. So the research like this, I think, can particularly help us figure out what works for real people in the context of their daily lives, whether those are providers or patients trying to make use of information and data to support their health.
Jan, I want to add one comment to what you said. You spoke about the value of access to all data or a longitudinal record in terms of improving both the efficiency and the value of the care provided. But I always like to point out the safety issues as well. Yes. Again, as a provider, when I have access to data from beyond my institution, and that is automatically brought into my record and integrated and displayed, it really allows me to provide the safest care. You know, learning about a medication allergy or a medication that's being taken that I wasn't aware of, that the patient may not have mentioned. You know, sometimes profoundly important information will show up, and the patient goes, "Oh yeah, I forgot to mention, you know, that." So I think especially for providers who are providing acute or episodic care, having that data available, brought in, and displayed all together is incredibly valuable.
When I think they've found, in particular in studies of open notes, that a significant number of patients who view their record and the notes about their record have comments about the accuracy of that information. And I'll give a very quick instance that I went into my patient record at a highly regarded academic medical center I visited here in Virginia, and found that they had recorded my BMI at 64. I believe the weight that triggered it was 2.5 times my actual body weight. And I'm not sure yet, honestly, whether it's actually fixed in the record or whether they just suppressed that from display to me. But it highlights the fact that patients often can find errors in their charts that can also significantly impact care.
I'll tell you, that sounds like they measured you in pounds and then entered it as kilograms. Because that's
probably what happened.
roughly the conversion factor.
So
yes, indeed.
At fighting trim, I'm not that bad.
So yes, I can tell you as a EHR user that those errors can indeed be corrected very easily, though not many users bother to do so. We just have a couple of minutes left, and there's one more question that Liz entered, which I think is really yours, Jan.
They asked about, Liz asked whether in talking about comfort with sharing with the data with a doctor, whether that was inclusive of other healthcare professionals and with the healthcare system. And while I didn't show these slides, we did ask more granular questions to try to suss that out. The fact of the matter is that the more personal it is, the more that they knew who it was they were sharing with, the more likely they were to share the information. And that the more comfortable and trustworthy they found their individual provider, and that is providers across different kinds of specialties, the more likely that they were to give a halo to the institution as a whole. But sometimes people trusted their providers more than they trusted the healthcare institutions, and then trusted the healthcare institutions more than other kinds of institutions that might have access to their data.
So we're coming to the end of our hour together. Thank you all for participating, and thank you especially to Liz and Nancy for the great questions. I think it was Nancy that put into the public chat on the right side of your screen the link related to the HIMSS virtual march for California telehealth. Again, I think we're all well aware that the COVID crisis has blown the lid off of telehealth in California. My understanding of the metrics is that fully 50% of patients have accessed telehealth in the last 3 months. I know that many of my patients have and will be, and actually it's just 10 minutes now, my next patient. So I fully hope that we are successful in integrating telehealth into our ongoing care processes, because it is really so efficient and satisfying for so many situations, and will allow us to focus our face-to-face or skin-to-skin care on the specific interactions where that's really required. So we are at time. Thank you all for your participation, and have a wonderful day.
Thank you. Great to meet you, and I'll be in contact.
Great.
Okay. Take care. Bye-bye.